Welcome back, guys, to a brand new episode of Global Med Talks. Today is episode 10, and I'm here again with Abdul-Aziz Ansari. Thank you for coming on again. And this is a special episode because it is my 10th episode, so I wanted to make this special. And this is also the second episode where I'm doing a video as well. So, how do you feel?
I feel good. I think the last one it was alright. I saw quite a few things online. I think I posted a couple of things myself, but didn't get too many views. Yeah. But there was a few from your page, I know.
Yeah, there was a few. I posted a few clips on my page as well on TikTok. Like and follow. And a few of them did good, but then a few of them did really bad. But there was one good. There was one episode. Yeah. There was one clip that did really well. I don't know if it was for a good reason or a bad reason, because a lot of people were, they were talking in the comments and some people were arguing. I would really consider it arguing because they were saying they kind of had a point, to be honest with you. But I feel like they were exaggerating their point to an unfair level.
What was like the main thing out of that?
We said that our knowledge, we weren't like at a disadvantage compared to UK students. Yeah. And I was only talking about the knowledge part. And most people in the comments, they agreed with the knowledge part, but then they started making their own arguments saying, oh, well, your communication skills are not are on our level. I mean, fair enough. I see their point.
Yeah, when you look at it in a bigger perspective, where students studying in Georgia, obviously the communication is not going to be as good as like UK doctors, but even then,
the way they were saying it,
they're saying like we don't know what to do at all. Like
exactly,
they're acting like when the patient comes in, it's like the patient comes in, it's like it doesn't really make sense. Like we're not like so stupid that we don't know the actions or what to do. Maybe we might be a bit rough around the edges. Like we might not say it in the way that people would expect somebody like from the UK that's learned the same thing. But you get that, like that's what your FY1 year is for. You're going to be under a lot of people. Literally everybody that is above you is going to be senior to you. You ask anybody for help, you're going to be asking FY2s for help at some point. Yeah. So if we can get to the position where we would be in an FY1, I think to get to that position, you have to be pretty like intelligent, hardworking anyway. Yeah. For us to get the communication skills based on what we've learned, do you really think it's going to be like that difficult as to what people are making?
It's not going to be that difficult. And to be fair, a lot of students, if you look at the students in our uni right now, a lot of them are well spoken. Do you know what I mean?
That's the thing. I think a lot of people see, these guys, they're just from Bradford. Well, you're not even from Bradford.
Maybe they've seen a few bad examples as well.
Yeah, that's the thing. Like they might just think that this is how we are like to patients as well. But this is different. Like it's completely different setting. Yeah. When you go to clinics, when they haven't seen us in our OSCEs, like OSCEs are completely different as well. So that's another important bit, but I think people do kind of like blow it out of proportion. They're just like
definitely
we don't know anything. 100%. Like we don't learn anything here.
And this is the thing. Like even with all that, I still do advise international students get their work experience in the NHS before they graduate as well, and not like just one rotation for a few weeks. Every time you go back, you need to be getting experience because look. In the comment section, they do have a point. Maybe they exaggerated the point a little bit, but they do have a point. Yeah, and we need to take a lesson from this and actually pull up our socks a little bit and do the extra work that we need to do because we need to at the end of the day. Yeah,
because when you do think about it like that, it is easier to get in abroad. It's easier because there's more spaces. It's not as hard as the UK. It's not as difficult as competitive. But then on the other side, we have to work twice as hard just to show that we have the same experience. Like to get these rotations as well, it's like a little bit of nepotism. Like you have to know somebody that knows somebody, or like within your family to get these. So we can't really choose about which ones. Like for me now, I'm doing my urology rotation. So ideal situation, I would want to go back and do something like in a urology ward. Maybe that's not possible for me. Maybe I might get something that I haven't studied yet, but it's still good for me to like learn how stuff works in that ward. But it does, obviously, when you do it in the right order. Like we'll have done surgery, we'll have done gynecology, urology, and internal medicine as well. So cardio, nephro, and pulmonology. So if we could get experience within any of those wards, it would be a lot more beneficial than if we were to do it like a year ago when we hadn't gone through any clinical knowledge in it.
And I see this is the thing what my dad was saying as well, because he told me when I came to Georgia, learn the language. And I'm seeing the benefits of that now, and you are as well, because you've interacted with a lot of people in Georgian, and so have I, especially in the clinical setting as well. Obviously, we're not saying we're fluent Georgian speakers or anything, but what it does is it gives you an upper hand and the teachers, they do get impressed with your Georgian, even if you do speak a little bit.
Yeah.
And then they will give you more opportunities to, you know, interact with more patients and do more procedures or help them assist in more surgeries and stuff. So definitely learning Georgian is a big thing. I don't know why I put that out there. I think I just went off a bit of a tangent, but it is an important topic.
I think following on from that though, like the experience that we do get here, it is like very unique. Like, because when you look at the stuff that we have done so far, so right now I'm doing surgery and urology. For urology, it's pretty much like we get theoretical cases and we discuss a lot of those in the classes. There's not many patients for urology, and also it depends on the timing of the classes. One thing here that is completely different, you don't have ward rounds like you do in the UK. You go to the clinic as and when there are patients. So when my clinic is like 6 p.m. in the evening, nobody's getting any procedures done at that time. So we will just do theoretical cases. If there's anything to see, then the doctor will tell you, come at this time earlier in the day, and we'll see this patient. So that's how it works here. And also for surgery, like we've seen some mad stuff so far. Like I was in one the other day, and it was a continuation of like a diabetic foot amputation. I think they were trying to recover as much tissue as they could. So like he's had a couple of them before, and you could see like there was granulation tissue, and they took off like the vacuum. It was like the vacuum healing process there. So they took it off from before, and they were letting like, you know, the secondary intention healing. They were letting that take part. It didn't work, so they had to get rid of, like, this was the last toe on that foot. So they were getting rid of the big toe, and then they were just sort of like closing the wound and then letting it vacuum heal again. So that's the sort of stuff that we see. And even like tomorrow, I don't know when this episode's going out, but like tomorrow I've got another shift with my doctor. So he's told us come to the clinic and he'll let us observe with him. He'll let us take part in certain things. And I think that's something that you have a lot more freedom here. It sounds bad, but there's a lot less laws here that prevent students from doing stuff. But in terms of actual clinical experience, you would be under the guidance of a supervised doctor, obviously, and they would they will make sure that you don't do anything like stupid, and they'll only take you if you show that you're hardworking and show that you've done enough in the classes. So that's another important point. Like, which students in other medical universities, maybe they do this in like Bulgaria and stuff, but in the UK, I know, like, if you're in medical school, you're not going anywhere near a surgery, like, to take part in one.
I mean, they do. I feel like they do.
Do they?
But maybe, yeah. I mean,
like to the point where they're like, the person that is secondary to the actual doctor there, like, you're helping them do the suturing and stuff like that.
I mean, maybe that's the thing.
That's the thing. We don't know because we don't have that
Drop in
experience.
the comments if you actually do assistant surgery.
It's important to know, because I think people think we don't see anything over here, or they do stuff really backwards. But in fact, that's not the case. And a lot of the stuff that they do here, they follow guidelines as well. They not just Georgian guidelines, but they tailor it to like Europe, or they tailor it to American guidelines. So it is very similar overall. But I don't know what's it been like for you?
No, it's been really good. I mean, the experience itself has been very informative. Like, you learn a lot of stuff on the clinics as well. And people say, oh, you're in an Eastern European country and the doctors don't know speak English. They don't know how to speak English. They don't know how to communicate with you properly. They do. Like, our doctor, right? He's gone to all these different countries. And I remember this is the first time I went into his office here. I went into his office and he just had like a full wall of certificates. He must have had like 50 different certificates.
Was this for surgery?
For surgery, yeah.
He was telling me about
and he's been to Germany, he's been to Spain, he's been to Italy, and he's worked in Georgia, he's been to America. I'm like, oh, this guy's some next level like surgeon. And his English was fluent.
Yeah, that's...
And, he explained this procedure beforehand. And I don't think there was any difference if I was in the UK, to be honest, because any question that I had, I would ask him and he'd tell us, oh, this is what's going on, this is why it happened, and explaining why something is happening. That's very important as well. And then he'd give us resources to learn from, which is very good.
I think another thing that's quite important when people say they don't know how to speak English is the fact that in Georgia, in all of the countries, the doctor can't teach in English. Like, they're not allowed to teach in English unless they've graduated from the university while studying the English medical degree. Like, they can't so for example, they can't learn it in Georgian and then decide they want to teach it in English. They have to learn it in English and graduate in English. They're doing the medicine. They're not only doing the medicine degree in Georgian side by side, they're doing it in English as well. It's the same knowledge, but obviously it's different. It's a different language, so it's going to be hard for them. But they have to graduate. So most doctors here, they have 2 degrees, right? So I know, like, one of our doctors, Dr. Anakashia, shout out to her. She was the one that explained it to me. She said she was doing it in Georgian and she was doing it in English. So she had twice as many exams. She understands how hard it is to be a student, so she tries to give us as many resources and stuff. So when people say that the doctors here don't know how to teach, I feel like that's really unfair. Because when you look at the flip side and you see the countries that they've gone to, and they've invited lecturers as well, like Tinatin, the physio one. So people like her, they go all around and they're seen as very special guests in other countries because of how much they've learned and how the knowledge that they have and how they can teach. So if we have access to those types of teachers weekly or like every day whenever we have classes with them, I think it's very unfair for people that are sat at home on the sofa and they're just messaging behind the comments saying, oh, these teachers don't know how to speak English, they don't know how to teach, when in fact they're a lot more hardworking than people do think. So it's another important thing to...
And most of the teachers, they end up going to America as well.
Yeah, that's...
they sit the USMLE and they say, okay guys, in a few years I'm going to go to America. And they do this. Tinatin, one of my previous teachers, she went to Oxford as well. She's done loads of conferences internationally. She's gone to different countries. She's got the Diana Award as well. Like, all the teachers, not just her as well, like Archil for surgery, he's done a lot of stuff outside of his career. It's really good. Like, they're very, very talented, very skillful
I think
teachers.
Overall, then, like, in terms of teaching standards here, I think is above average. If you would say, well, I don't really know what
for
the
Eastern
average
Europe
is.
anyway.
Yeah, if you're saying like Eastern Europe and what people think in their mind, I think it is above average here because
it's better than what people think. What a European
obviously you do have some teachers that don't teach as well and they don't have as much knowledge or experience, so they can't explain it in different ways because it's not their first language. But I think you have that everywhere. Like, how many you see all of these memes and stuff and videos on like TikTok, and like, I turned up to this lecture and this is how and this is how the teacher's teaching, or you turn up and you don't even understand what the teacher is saying. Like, this is not disrespectful to those teachers. It's just, it happens everywhere. It's not like Georgia might be the only place that it happens. It does happen in the UK as well.
It does.
So,
and I was at a UK uni, and I don't want to mention any professors' names or anything because I might get in trouble. But there was a professor at our uni who just everyone hated him because he was just reading off the slides.
Can you say the uni or no?
No.
Don't say the uni.
They're going to file a lawsuit against you or something, I don't know. But there was one teacher who everyone hated because he was just reading off the slides. Another teacher, he was passionate about his subject. He was teaching psychology. But it was to the point where he'd spend like half an hour on the first slide and then another half an hour on the second slide. And he'd just tell you to learn the rest of the slides by yourself.
I feel like in those situations, like, I know they have like scanning systems in the UK where you have to go in and out of you have to scan to lecture, and here they don't do attendance. Like, well, they do attendance
now. They
started because of like GMC and stuff. I think that was when we came. They started making sure, because we have to have the clinical hours. But I think a lot of the time in lectures, me like specifically, I know if I'm not going to benefit from the lecture, then I do my own notes like during the lecture, like not even to do with that class, but I'm just there for the sake of it. And I feel like that there's a lot of students that happens to where they're kind of just there for the sake of just showing their face, because I don't learn anything from... I can't learn. Like, when someone's speaking information, I can't retain that information. There's very specific ways that I learn, and it's like flashcards or like writing stuff down. So
that's a very good point you mentioned, because I was thinking about this a few months ago. Why hasn't the way we've been taught medicine changed? Like, we've been taught the exact same way as the physicians were probably taught 100 years ago. And you're telling me they haven't found any way to like improve on how we learn. In
actual unis, but like there's always resources and stuff that are improving. Like I was showing you one before this, the one that I use MedSnap. That was they've got so many different things. Like they've got preclinical version and a clinical version. So right now I'm using the clinical version, and what I do with that is I literally put all of the you can put your own information in there to make flashcards, or you can use these patients that they've got. I think they're still developing it as well, but they have like simulated patients, and they come to you with different problems, and you have to sort of like do investigations, you have to do examinations on them, and you have to give them treatment. And that's the sort of stuff where what we're learning in uni is actually coming into practice. And obviously it's not going to be as good as actually seeing it happen.
It's a bit like getting grilled on the wards, isn't it?
Yeah, but pretty much like when they ask you, because nobody else is going to do that here. But even then, like in the seminars that we do have, the doctors ask us, like, when they give you theoretical cases, that is, if you saw a patient in the same thing, you're going to think in your head like, oh, I learned this when I was in Georgia. Like, this is what he said, like, what would you do, what are the steps? So
and that's the things you remember as well.
Yeah,
you don't. I don't know. Like, I don't know about most people who are watching, but you know when someone asks you a question about, like, let's say abdominal aortic dissection or something.
Yeah.
When I think about it, I don't think about, oh yeah, there was like a few months ago I learned about this lecture. The teacher said this.
Yeah.
And I don't remember the PowerPoint in my head. What I remember is like case scenarios and stuff,
yeah,
like
I remember there was a
the
case,
patients that I've seen.
and this is the same thing, like, you know, when doctors get so much experience, like for example a GP,
Yeah.
when you start doing these cases initially, you have to like sort of think of the process in your head,
Yeah.
and then after a while, once you've seen like how many patients with GP see,
Loads.
like they see loads,
Yeah.
so after a certain while you go on autopilot and like you already know, like, when they get to a certain level of experience, they can just blitz through an appointment and they can pinpoint it because they've seen it so much.
Mm-hmm.
And it's not like them being negligent and stuff, it's just they have so much experience that they know what to look for, and they can sort of remove themselves from the individual patient and look at it from the outside. They know what's more likely, what's not likely, and if there's anything that's giving them red flags, then they can choose to investigate it, which is one of the most important tools. You cannot be expected to know everything. You just need to be able to sort of diagnose and go in the right direction, because if you can't do that, then there's no point of having the information ready. Because you could give somebody the information, like they could know all of the information, but if they didn't know which steps to take and what to do next, then they wouldn't be able to sort of help that patient in it. So, and
a GP said to me when I was on rotation, yes, whoa, like international student getting UK experience is crazy. No, it is important, guys, get UK experience. But he was saying that what GPs need to do is they need to deal with uncertainty.
Yeah.
Because, you know, when we look at these clinical vignettes on MedSnap or whatever, or clinical scenarios for exam questions, it's most of the time it's to the point. Like, you know exactly, or everything that you need to know for the diagnosis is in the question somewhere. And there's not really that many if, buts or maybes. Do you know what I mean?
Yeah.
So, but in the real life scenario, everything's a lot more complicated.
Like
there's
that.
always,
so many...
but this, or but that, if,
and the
but
fact
maybe.
that it's a real person as well.
Yeah, and it's a real person. So you need to get good at dealing with uncertainty. And what he meant by this was, picture it like there's a spectrum of the most likely diagnosis and the least likely diagnosis, or like the most common to the most rare. And he said something to me that will stick with me forever. He goes, common things are common. Do you know what I mean?
Yeah.
So always start from the common things. If someone asks you, okay, what are the most common complications for a pregnant woman or something, if you straight away jump to eclampsia and stuff, like, you have to start off with the common presentations, like back pain and stuff, like morning sickness, stuff like that, and then work your way up to eclampsia. There's no point jumping to eclampsia straight away. Do you know what I mean?
Yeah.
You have to work your way up, because most likely than not, it's probably the most common diagnosis, and that it comes with experience again. And you can't really learn it from a book or something, because if you just like a textbook worm, then you're going to jump to these really niche topics.
The ones that you learn are the ones that got massive paragraphs about. But in reality, the ones that you see the most written right at the beginning, they've got 3. They're like, the most common symptoms are this, this, and this, and that's the bit that you start at. But because maybe when you're learning in the book, it's like 3 or 4 pages talking about one topic, like eclampsia or preeclampsia or gestational diabetes or something like that, and that obviously that's going to be in your head, because that's what a lot of the studying was. You learn about that when you were in med school.
Exactly.
But you need to start at the most simple stuff.
Exactly.
I never thought about it like that.
Yeah, you need to consider everything, and you need to mark out what's the most likely diagnosis, what's the least likely, and what's in the grey area. Do you know what I mean? You need to rule it out, and in a way you have to talk this through with the patient as well. Okay, I don't think it's this because of so and so. I do think it might be this because of so and so. So let's do this treatment plan. You know what I mean? It puts the patient at ease as well, because it tells the patient, okay, the doctor knows what he's talking about. He's considered all the possibilities, and he's given an actual educational treatment here. Education guess, and not education guess, but educational, like a conclusion, whatever what he thinks. Anyway, and it also builds trust with the patient as well,
which is important, especially as a GP.
And this stuff, I'm going to keep saying this because people are going to clip what I'm saying and keep saying the same thing. This is why UK experience is so important. Because I only learned this from doing a GP rotation in the UK. No one taught me in Georgia how to do this. And that's why I'm going to continue to go every time in the holidays to do some more UK experience, because I'm going to learn more things. You never know. I'm going to go in February. a doctor might teach me something else that might be, you know, really important.
Yeah, I mean,
that's why it's
if
really
there's any doctors watching this, if you're watching on TikTok or like YouTube, then you got two like proper good students here. If you want us to like, if you want to teach us some stuff, or you want to like give us some space in your clinics when we go back, then just DM him, DM me, drop a comment on here, just let us know, and we can get it sorted, because, you know, this is the reality. We're trying to build a future for ourselves, but it's hard. We have a lot of different things that we need to try and overcome.
Yeah, it is hard to get UK experience, because I've messaged these hospitals and most of them said, oh no, we're not really supplying clinical work experience for students right now. If you do want work experience, you kind of have to know a doctor like personally,
that's the thing.
And you have to go through it like that. So yeah. Right, OSCEs. What's your experience been like in OSCEs, and have you got any funny stories for us?
To be fair, I'm trying to think, because we've been doing it for 3.5 years.
Yeah.
I mean, which semester would there have been something? I mean, I know I made that video recently where I was like, where I was taking the mick a little bit. Because people are always like, we don't know anything about OSCEs abroad and stuff. So I was kind of like just taking the mick. But in terms of actual like fails, for me personally, like the worst thing I've had happen to me is like the blood pressure machine just like it completely like fell apart.
No way.
I don't know if that's just because it was like an old machine or what, but I was like putting it on the arm, and like it literally like it just like fell apart, and I was so confused, and I don't know. I'd
be stressing.
I kind of just explained to the examiner like, look, this is what's happened.
Yeah.
Obviously. I think, you know what, that was a teaching point, because I just ended up taking my own equipment.
Was it your fault though, or was it just like the equipment?
No, I think it was just old. I actually don't know what happened. Like, you know, the metal thing.
Yeah.
It stayed on that side, but then the other side fell off. So I was like, I was so confused about like how that happened. But I mean, I did like it wasn't like at the beginning of it. It was I did like the rough one. I did the rough one to find out which level it was around. I was trying to like fine tune it to get the exact one the second time, and it fell off then. So I was like, I got the first number, I got the systolic one, and then it fell off, and then I was like, I just had to kind of like blend it, because I knew like the diastolic one. So I did make up a number. But I don't know where.
120 over 80. This is the
no,
classic.
I did 120 over 80. I had it was 108 or something. It was something like that. But I didn't know what the bottom one was, so I just said like 70. I just said 72 or something just to me. And then I did tell her at the end of it, I was like, oh, by the way, this is broken. I didn't break it. It just fell off. So that's what I had to kind of do.
Did you pass that station though?
I'm assuming I did. I mean, I'm here now. So I think that was like a couple of years ago. But in terms of like, in terms of another one, I would say, I'm trying to think. Well, we all had the classic one where you're trying to, these dummies are not really good in it.
Yeah.
So, you know, when you're trying to find the vein.
Yeah.
And you're trying to get that pushback, you don't get that.
Yeah,
like, it's not really that good. Like, you put it in, you know you're in the vein, but nothing comes out. And you just, you put it, it's a bit weird, because the examiner, they stand up and they look at you putting it into the vein. And then you feel it going to the vein, and then you just sort of look at them, and then they look at you, and then you look at them again. And it's
so nonchalant about it.
And then when they look away, you just sort of like squeeze the arm from the But I didn't even know I was doing that. Apparently, he goes, don't squeeze the arm to force the blood. I'm in the vein. But I didn't know. I didn't mean to do it. Like, I wasn't actually doing it. But I was like, I don't know what's going on with it. Like, it's not working. It's not going in the thing. And I had to do it like 4 or 5 times to get, but I knew I was in the vein, like I could see it go into the vein.
Yeah.
And it was just like some of the dummies are like a bit crap.
Yeah.
So like you can't really do much with that. I mean, that's the worst that's happened to me. You know, it's worse because you know you got the gloves on, and then it's like your fingers are sweating when it's not going. It's like the third time the timer's going off, and you're like, I can't find the flipping vein. That's the worst thing.
You know, when the timer's going off as well, and then they always have the audacity to tell you you have 1 minute remaining.
Yeah.
And you just like mid-procedure. You're already stressed because it's an OSCE exam here. And now you're even more stressed because this guy's yelling at you. You got 1 minute left. And then you're even more stressed because it's going wrong as well. It's crazy.
I don't know. What about you? Have you had any situations like that?
Yeah. I had one OSCE station where I had to give alcohol advice to someone.
Yeah.
Yeah. So the whole thing was going fine. And then halfway through the OSCE station, I just told them, okay, you know, you need to find some new friends. To me, at the time, I mean, I understand now why it's a bad thing, but at the time I was thinking, okay, well, you know, if these friends are influencing you on drinking too much alcohol, and if you want to quit, then maybe you should change your circle of friends. And then she just looked at me, she goes, what do you mean? I don't want to change my friends. So I was okay, and then I just carried on to the next question. I don't even know what to do. And then at the end of the station, right, she just said, sorry, doctor, can I just say something to this student? She goes, yeah. Never tell someone you need to find some more friends or like new friends or something. I was like, alright, okay, I'm sorry, I apologize. I failed that station, but generally the OSCE was very good. So I passed the OSCE in general. But that station itself, I stuck with me for a very long time now. But anyway, another station. This is not like in Georgia, but this has happened when I was like doing a rotation in the UK. A doctor was saying, "Oh, I want you to do a cardiovascular examination on this patient." The patient was an old lady, and the lady was, as I was getting my stethoscope ready to, measure the heart rate. She goes, "Oh, if my heart starts beating faster, it's because I got a young, handsome man in front of me." I kid you not, no word of a lie. Yeah, I looked at the doctor. I was like, and the doctor knew I was a bit like, what was going on. So the doctor had to tell the patient, "Could we please stay professional, please?" I was like, okay. So I just finished it off. I mean, bearing in mind, it was an old patient anyway, so it kind of makes sense.
Yeah.
But it's still, it was like, whoa, what's going on? And it baffled me a little bit, but yeah. That was kind of
I'm
funny.
trying to think if I've had any other. I've just had misunderstanding because my accent is not easy for people. People from the UK struggle to understand my accent sometimes. People from down south. So then when I come here to Georgia and I'm trying to like speak, I was doing a depression history, like from the patient. I was asking him like all of the questions, and I asked him like, it got a bit heated because I was angry because this happened a few times before where they don't understand me, but it's not really my fault. Like, I try and drop my accent, like I speak a lot slower than I'm speaking now, and I'm speaking with like a very neutral tone in the exam.
Yeah.
And I basically combine two of the questions into one. I said one of the is like near the end of the station, and I said, what did I say exactly? I said, have you had any feelings of suicide, or have you harmed yourself? So that's like self-harm. Asking about self-harm and asking if they've had any ideations of suicide.
Yeah.
But the examiner didn't understand this, and they marked me down on that. So I lost like 2 points for that question because they're saying I missed it. And at the end of the station, she turned around and she said to me, "Oh, you didn't ask about self-harm." And I was like, "What do you mean?" I said, "Have you had any feelings of suicide or self-harm?" And then she asked the patient, and that's what annoyed me the most, because she goes to the patient, "Did he ask you?" And she goes, "No." And I was like, "What do you mean?" I literally said it. I said it in one question, but because that's normal. You don't ask somebody. You wouldn't ask somebody like, "Oh, have you harmed yourself, or are you going to commit suicide?" Like, if they said no to the first one, then why would they say, like, surely that's like progressive, innit?
Yeah.
So that's what my thinking was behind it. If somebody has harmed themselves, then okay, maybe they have had suicidal ideations. If somebody hasn't harmed themselves, you're gonna jump to suicide. You're gonna put the idea in their head, or like maybe you're just saying that to them. So that's why I was like,
maybe I think it is two separate things. That's where I think the problem
that's
was.
why I was
think they want
confused.
you to, because they want you to separate the two things, because sometimes you can self-harm, but then you won't commit suicide. Do you know what I mean?
That's
it's
the
like,
thing, but like, that's why I gave it in both. Like, they would say, if you gave that answer to a patient that I've self-harmed and I've had ideas of suicide, or I've self-harmed but no, I haven't. So I gave it. I don't know.
It's a lesson. It's a learning point.
That's the thing.
It's a learning point.
I don't know what it would be like. If anyone knows if they've had something similar, then let us know in the comments. But that was the fails that I can think of.
Yeah. But yeah, those are the fails that we've had personally. I've got some Reddit stories. I searched up on Reddit. Listen to this. Right. First guy. He said, "I was panicking, looking at a knee x-ray, and identified a big fat demon of a bony tumour and recommended ortho get on the case stat. Honestly, a headline grabbing tumour. Like, seriously, what is this evil behemoth? The x-ray was unremarkable. I had discovered the patella."
Oh my days.
The patella, for all you like non-medical students out there, is just the kneecap.
Yeah. Oh my god.
So that was kind of funny. Alright, what about this one? Right, someone said, "This was during my first year. The station was performing a manual blood pressure reading." Oh, same as you.
Oh my god, I feel like this might be my story.
"Did the estimated blood pressure reading, which was okay. Then proceeded having to do an accurate blood pressure reading. Pumped the machine real high, then deflated it, and was listening intently for the cough sounds. After 30 seconds, still wondering why there is no sound even after I deflated it to below 60. I checked my stethoscope, then realized the diaphragm was lying on the table. I was listening to thin air.
Oh my god.
This is the thing, like, do you know when you're in the heat of the exam?
Yeah, like you forget
you forget certain things, and then you just kick yourself after you realize. And I feel like, I don't know how the examiners keep a straight face sometimes when these happen.
I feel like, what was something that I missed? That was, oh, okay, yeah, I think I was doing like a vascular exam, and I forgot to do the carotid artery. Like, I did every single other artery, and the examiner was Lavan. He just turned to me, he goes,
Where's the carotid?
You know that feeling when you finish it, and he turned to me and he goes, are you finished? I was like, yeah. I go, why? He goes, did you miss anything? And I was just thinking in my head, crap, I missed something, and I couldn't tell what it was. Like, in that situation, I didn't know what I missed. And he goes, you did all of the other arteries, but you forgot to do the carotid artery. I was like, this is the first one.
That's so annoying, because like when you think of artery, that's the first one you think of. Yeah?
In the exam, like, I did all of them, like minor ones or the ones that you do after. I didn't do the carotid. Like, that's the main thing that I forgot.
And this is why practicing is so important. Like, just, you have to make sure you just run on autopilot during the stations. Just practice like 8, 10 times, 100 times. If
I've got my barrier OSCE in like 4 days. I've got that one's gonna be. I've got I've got female catheterization, and then I've got wound cleaning for surgery. So then, let's see. We need practice. We're gonna practice that one in uni.
That's the one that I did last month. But what I would make sure is just make sure you mention the history part and allergy part as well. Yeah, like get the history, because when you communicate with the patient, that's very important. Yeah. There's another one. Listen to this. This is a small one. Oh, this is similar to yours as well. A few years ago, a student in our year asked the patient actor whether they'd ever successfully managed to commit suicide.
Oh, okay. Mine wasn't that extreme.
Bro, imagine the patient's face when you hear that question. So, well, I'm sitting here right now, so obviously.
That's a bit dopey. I feel like that one. Oh, I don't know. Maybe English wasn't their first language. But I'm not trying to judge.
Honestly, these are all from Reddit, by the way. So don't come in the comment section. Oh, you European students don't know how to do anything. This is literally just from Reddit, from like random unis across the world. Listen to this one. Oh, this is bad. Venipuncture station in first year. So when you're taking blood. Tried to flick down the needle guard after taking blood. Apparently, I had not put the needle onto the vacutainer very tightly and inadvertently pinned it across the room at the examiner.
Oh, that's
Luckily, Luckily, there was no needle stick injury, but I had to redo that station.
Oh my goodness. I wonder how how does it work? Like, I don't know. When they're doing like OSCEs for like taking blood out and stuff, do they do it on dummies as well? Or
dummies. Definitely in the first 3 years, because I was in UK med school for the first 3 years, but after that I don't know what happened. Maybe they do some like examinations in the actual hospital settings where the doctor had to sign off or something, but I'm not too sure. Let us know in the comments how but they
do like magistry, like they'll ask, can the student do it, like, when they come out, because I know I've been in hospital and there's
something, I mean, in our uni there was something called DOPS, so you have this certificate to show that you're competent in doing this. Okay. So after you get the certificate, I think you do it in second year, and they're really strict about it as well. You have to follow each step. You have to be really, really precise. Once you get the certificate, and then you can do it in like practice.
So that might be like this barrier OSCE. Like you can't miss anything. Like if you miss one single thing, then they fail you in it. Yeah. So it's not as easy as people think. Like, oh, you can just you can just fail your way through. Like, you have to get 100% in this OSCE, or you fail the whole thing. Like, you have to do that rotation again, which is mad.
Right, I've got one more. Do you want to hear it?
Go on.
Okay, go on. This is kind of a big one. So, this guy, he said, I was nervous as hell before my mock OSCEs. Standing outside, prepping myself like this is going to be it. Cardiovascular check, I'm hitting every point. This is it. Years of practicing on my pillow finally pays off. I finished strongly with, to finish this examination, I would request an ECG, bloods, including a BMP and chest x-ray. Booyah. Examiner looks at me with a bemused expression. Balls, I'm thinking, I'm sure I didn't miss anything major. Inspect, palpate, auscultate, yeah. The examiner looks at him and says, that was an excellent cardiovascular examination, but this is a respiratory station.
Oh my days. I feel like at that point, just Put the fries in a bag.
I know, just go home. Just walk out.
What would you have to do in that situation? Because imagine you drop a killer one like that, yeah, and you're just like, shit,
Yeah.
I haven't even done the cardio.
That
done
is
the
so
respiration.
annoying. That is so annoying.
That's why I'm happy that they keep ours in the same room.
Yeah.
And they might.
Well, we have 2 stations in the same room. We don't have like all of them in the same room.
Yeah, like, if we're gonna do this one, like now we'll have, just for sake of easing, like they'll have multiple examiners across the rooms, but then you just switch the rooms in it.
Yeah.
So, or you just switch the station in the same room. It depends on how many people there are. So, yeah.
But yeah, those were the funny ones that we've read, and we've told you our experiences. Please comment if you've got any funny experiences in OSCEs. We would love to read them. And we might do a part 2. You know, if they're funny, if they're funny, then we might do.
We can read all the ones from the comments as well and read their experiences.
Yeah, true. But anyway, thank you guys for listening. Thank you for coming on. So, is there anything else that you want to mention?
No, I mean, if you guys are watching this, then you might have heard that we do use MedSnap, and that is, well, it's not the sponsor of the video, but it is a good tool. And you can also use my code, which will be in the description, for 25% off. And yeah, I do recommend it. I never recommend stuff without using it myself, and trust me, I've been chilling most of the time. Well, not chilling, I've been handling the stress of med school, because you know, they've got so many different resources on there. They've got flashcards, they've got questions, and they have the clinical patients, which you can do. So yeah, make sure you check that out, and it is a very good tool for you guys to use, whether you're an international student or whether you're studying in the UK. It's beneficial for both of them.
Yeah, it's definitely beneficial if you wanna make it seem like you're getting grilled by the wards, grilled by the consultants on the ward, because this app, when you showed me, it was like, diagnose this patient, it's not this, what investigations would you do now? And then it will tell you why is this wrong, why this is right. So it's pretty good.
Yeah.
That's all. Thank you very much for listening, and I'll catch you in the next episode.